Hello and welcome to another segment of Western Wisconsin Journal. I'm Jamie Johnson, the government and political correspondent, legal correspondent. And today, it's a casual Friday. I'm normally in suit and tie, but we do have somebody that's in coat, and it's a guest that we recognize, Dr. Paul McGinnis. Doctor, welcome to the show.
Thank you, Jamie.
And if folks recall, Dr. McGinnis, we had you on, 5-6 months ago, probably. And we said that it was highly likely you'd be back, and here you are. As much as we don't want to be talking about COVID-19 still, I think circumstances have made it such that it's not going to be going away anytime soon, but we're at least on a good trend compared to 6 months ago, correct?
Absolutely. I mean, compared to where we are 6 months ago, there's been significant improvement. 6 months ago was December. We were just finishing our November peak, and we're in a much, much, much better place.
Right. So let's pick up kind of where we left off. I know back then we were talking about just the startings of vaccinations getting approved. I think Pfizer was approved and Moderna wasn't at that point or something like that. Now we've got 3, including the Johnson & Johnson single dose. And there's been incredible amounts of information and disinformation and so forth. So we want to get to it. Where are we at? First of all, let's talk about the Delta variant. Why is that dominating the news right now?
Yeah, the Delta variant is dominating the news because it's dominating the COVID infections. So information that was recently presented by our county epidemiologist told us that in Wisconsin, in May, Delta was 3% of the identified sequenced variants. In June. In May. In June, it was 27%. In July so far, it's been 85%. It has become the dominant variant, the cause of COVID in the United States. In Minnesota, it's now about 75%. So it's becoming the COVID infection.
All right, and let's, when we talk about variant, what is that and why do they have these names of alpha, delta, epsilon, et cetera?
Yeah. So a variant is a mutation or a change in the virus. So viruses are constantly changing, evolving, modifying, and there's been several hundred mutations. I don't have an exact number over the period of time, but of those 5 now have become specific variants of concern. So ones that have identified as increasing the risk of infection to humans or increasing the severity of the disease, and also have become significant penetration into the population. And
so the difference is when these variants become dangerous is level of infectiousness and then level of severity of symptoms.
Correct.
Okay.
Transmissibility infections.
And we had heard the very first one was the London or English one, right?
Yeah, and that was alpha. So what they did was they switched from naming it after countries to naming it after Greek letters. So we have alpha, beta was the South African, delta would be the next one, and that would be the Brazil, back up here. Gamma would be the next one, and that's Brazil. And then delta is the one that, trying to remember where that came from. Yeah, anyway, and we have Lambda out of Peru.
Okay. So like most of them were kind of like South America, it sounds like so far.
So Britain, Brazil, South Africa.
Okay.
Were the 3. So if I misspoke, the beta was South Africa.
Okay. So we have different variants, and now how does that relate to the vaccinations? Because the vaccinations were being developed before any of these variants were identified.
Sure. So one commonality that the variants have is this spike protein. That's the hallmark of the coronavirus. That's why it has its name corona, like a crown, which has lots of protrusions. So this coronavirus has all of these spikes on it. The spike has remained relatively stable, and that's what the mRNA and what the vaccines are targeting. So they're helping your body to develop antibodies so that it can bind up the spike so it can't hook on, and the ability of your body to recognize those spikes and say, this is something that doesn't belong here, get rid of it, and also then programming the memory cells in your body to say, remember what this is, remember how to fight it off, remember how to get rid of it. And that spike has remained relatively constant. The other thing that has happened is that the antibodies and the memory that are produced by vaccination have shown to be effective against the slight changes in that spike as we've gone along. One of the concerns is if we get a spike that changes enough, then maybe our immune systems won't be able to recognize it either because we've had a wild infection or because we've had a vaccination.
Okay. Now, you mentioned those two areas of each variant has a level of infectiousness and severity of symptoms. How does Delta compare to the original?
Yeah, it's about 2 times more infectious. And it produces a higher viral load within the individual. So if somebody has Delta, there's more virus present that they then can spread into the environment as they breathe through those aerosols or those droplets, as you remember we talked about at the whole beginning of this thing. And it's about 2 times more infectious. So if you're in a room with Delta, you have twice as great a chance of getting an infection as you would have with the regular initial variant.
Given that it's twice as infectious, does that mean that masks are less effective on the Delta variant compared to the original?
They're not less effective. They still work very, very well. If you have an entire population that's masked and there are individuals within that population that have Delta, a smaller amount of viral exposure increases your risk of getting an infection. So the masks still provide the same level of filtration, the same level of a barrier between the virus getting from me who's infected to you as somebody who's not infected. But simply because less virus is needed to infect someone, there's a greater risk.
Okay. And when it comes to masks, there's people that saying they don't really work. They call them face diapers and a lot of derogatory terms, unless it's an NR, 95 mask?
Yeah, N95, yeah.
N95. So does a regular cloth mask, can it still be effective when it comes to slowing or stopping the Delta variant?
Yes. And I think that masks have shown to be highly effective, and there's really, in the medical community, not a lot of question about that. And the masks have 2 big roles. First of all, it's a source control, and that's really one of the key things. So if I have Delta and I'm wearing a mask, my chance of spreading Delta to you is dramatically decreased, even if I've already been vaccinated, okay? Because there is a chance it can break through. If I'm unvaccinated, I have a lot more virus, so the mask is even a better benefit in that situation. The secondly is if you're wearing a mask, there is some protection if the Delta is in the air. We're talking, I'm coughing, there's a decreased chance of you're getting it. The biggest thing I think that people forget is that 40 to 50% of these infections are asymptomatic. I have Delta, you have Delta, somebody has Delta, they have no clue, they don't have any symptoms. And this is more common in our younger population. And so they can be spreading the virus all over the place and not be aware that they're doing it.
Well, what's the danger then if there's no symptoms? Why should you need to wear a mask?
Exactly that same reason. You don't have any symptoms, you don't know you have it, and so you're spreading it all over the place.
I guess my question was a bad one. If you have no symptoms, then and you give somebody Delta in a form while it's asymptomatic, are they going to remain asymptomatic?
No.
Okay.
So if I give you, I may be asymptomatic and have Delta. If I give you Delta, even though you're healthy, you could end up in the hospital, seriously infected, having long COVID, dying, any one of those potential risks. Or you could get it asymptomatically and spread it on to somebody else, to spread it on to somebody else, to spread it on to somebody else, and it gets to somebody who has a really bad outcome.
Now, our levels of cases are dramatically low compared to November, but they're still twice what they were a month ago.
Yep.
Because it's gone up about 100%. Now, this is where the debate is what is a level of number of cases that people would consider acceptable and we're just going to have to live with? Do you have an answer on that one, or is there?
Being a doctor, my level of acceptable is 0. I'd like to see no cases. And there are parts of the country and parts of the world that are doing that. It just means that there's not a lot of virus in the community and that the risk to folks is really quite low. I think that we are in a really good spot. I mean, our numbers are way, way, way down from where they were in April and in November.
And we attribute that to what?
I have personally attributed to vaccination. Okay. We know mask wearing in this particular part of the country was not phenomenal, but it did make a difference. But the vaccination has really made a significant difference and really brought those numbers down, because that's when we really started getting a large percent of the population in our area vaccinated was in that March and April time frame, starting with our older population and then healthcare workers and then working on down. And I think that's when we really began to see the numbers drop off. Okay. I think being outside for the summer has helped too.
Oh, sure.
Yeah.
We saw that the previous summer, although, we were making our back to school plans at that time, and there was a lot we didn't know, and we learned a lot over the last year. So here we are towards the end of July, and you just said that you attribute it to vaccinations. So moving forward, where are we at when it comes to vaccinations?
Yep.
And why has there been so much hesitancy? So off camera, you were quoting me the different rates for people, over 18, 12 to 18, so forth. So why don't you?
Yep. Right now, out of the total population in St. Croix County, we're at about 50%. So about half have been vaccinated. So about 43,000 people in our county have been fully vaccinated. That's a pretty phenomenal number. So that's a great start. That's a huge contribution to decreasing the spread of COVID and protecting everybody in our community. In that population of 18 and over, which is one that's frequently cited, we're at about 60%. So there's some real opportunities in there, and that's primarily in that younger age group, 18 up to about 50. And to get over that, it's much higher.
And by over that, in the first 6 months, everyone was stressing and I would say this would be true of the latter part of 2020, for example, anybody over 60 is the ones who were supposed to be shut down the most and limiting their contact. What would be your estimate of the vaccination rate for people over 60 in this county?
Yes, if you look at over 65, we're over 80%.
Okay.
So that population has really stepped up and is really doing a lot to make sure they're protecting themselves, but they also help to protect their community, so they're protecting their kids and their grandkids as well.
So that kind of slides down, as you said. The younger you go, the less frequent the people are dominant.
Seeing lower rates.
Yes.
Seeing lower rates. But interestingly enough, even in our population between 12 and 15, there's still about 30% of those parents and families have made a decision to vaccinate within our county. That's a significant number of kids. Is it where we need to be? It isn't. But it's a significant number.
Why is it so low? And we also see, you're talking about St. Croix County. I'm not going to ask you about nationally and everything, but we do see the states, they show the national map and different colors associated with each state. And you've got the southern belt of Alabama, Mississippi, and so forth with extremely low vaccination rates overall. Mm-hmm. And then we see the lower rates. What is the hesitancy with, what do you attribute that to?
I think that everyone is hesitant, everyone who has concerns about getting a vaccine and has made that decision not to get vaccinated at this point has a different set of reasons. For some people, it's a feeling that I don't need to do this because it's not that bad or I'm not at risk. For other folks, it's I really am worried about vaccines. Other people just simply don't trust government and don't trust those folks. Other people are saying, hey, it's just not been out long enough. I'm not really comfortable with the safety on it. Other people are saying it's not because it doesn't have a full authorization, that it's under this emergency use, or full approval. It's under this emergency use authorization. So
what is delaying the official approval by the FDA?
So I don't believe there's a delay. Typically when a manufacturer submits for a full approval of a drug, it takes months, sometimes years, for those things to come out. And I've seen that over my career for long periods of time where you'd hear about this great new drug, it's going to the FDA for approval. 2 years later, it actually shows up on the shelf and you're actually able to use it. Part of that is because they're very rigorous in terms of teasing apart all the data and taking a hard look at it. Secondly, they need minimum of 6 months of data, and we've just reached that point since the vaccines have been available, and really getting out into the studies and getting those data back in. Thirdly, I think the FDA spends a lot of time looking at the manufacturing process. How is it made? Is it consistent? Is it high quality? Are the standards being met on a consistent basis? So they spend a lot of time reviewing that process as well. It takes time to do all that. And they're being very diligent with it because they've got a lot of folks who are part of that process of caring for somebody. By giving them a vaccine, you want to make sure it's as safe and effective as you can, and that physicians and healthcare teams know what the risks are so that they can have a discussion around those risks with the individual as they're in the process of making that decision.
Based on what was known when the drugs were first, Pfizer and then Moderna were approved, what was that, December-ish, the risks that were believed to be then, How does that compare to what we know now, having 6-7 months of knowledge?
So the risks, the vast majority of the risks that were identified in the smaller studies that were submitted, the 30,000, 40,000 people, which is still pretty good size for drug approvals. Many drugs are approved on less than 1,000 or 4,000 or 5,000 people. Were primarily those short-term side effects. Basically, your immune system realizing something's going on and gearing up to take care of it. The fever, the achiness, the runny nose, just not feeling well for a couple of days. Those typical types of side effects that we're seeing, the soreness in the arm that is common with any type of a vaccination. So those haven't changed. They're still out there. Some people get no side effects. Some people get some of those. About 30% of people will get some, is the general feeling. In terms of anything that has come up that has been really scary or really concerning. I think there's been 2 conditions identified on a consistent basis. One is a very rare type of a clotting problem that occurs in the middle of the brain. This is a really, really rare one. That's occurring at a slightly higher rate than the background we'd expect, and the background we'd expect is extremely low. A few cases.
That was Johnson & Johnson.
That was the Johnson & Johnson, primarily in younger women. Okay. The second one is myocarditis, which is an inflammation of the heart, and that was identified with the mRNA vaccines, Pfizer and I believe also Moderna. And that one also was identified as being present at a very, very low rate. Let me look quickly here because I picked up the number earlier today. I believe about a rate of about 12 per million, 12 to 13 per million. And the thing I tell people is, yes, these are there. They're a risk. But you have to compare that to what is the risk of myocarditis if you get COVID. Well, that risk we know is around 200 to 300 per million.
So about 20 times worse.
Right. And the risk of the vaccine, you always have to compare to the risk of the disease and the potential for you to get the disease. And so it's not a risk against zero. It's a risk against the disease. So even if you look at this really rare clot condition, that has a low risk with COVID as well, that is higher than the risk with the vaccine. So still in those cases, the vaccine wins, in terms of being more safe than getting COVID.
Right. And we're hearing the statistics that basically 99% of the people hospitalized or dying are unvaccinated people at this point.
Yeah, someplace between 95 and 99%. And that's the thing that shifted with this pandemic. It's shifted from a pandemic of elderly who are hospitalized and dying and people with underlying health conditions. It's shifting down to younger people and unvaccinated folks. And the folks who are elderly who took that opportunity to be vaccinated, they're doing okay. They may still get the infection, and we've seen breakthrough infections, and they can occur, but that the risk of those more serious consequences is extremely low.
All right, so there's this concern about what's going to happen in the fall, because right now, whether everyone's outside, they're doing, you're distancing and you're outside and the wind is blowing. One thing that's different than a year ago at this time, we thought that it was a high transmission rate just by touching surfaces. Okay. We know now that that's not the case. But since it is airborne and we know that masks can be effective, will we be going back to masks for the fall?
Yeah, this is where I wish I had a crystal ball. I don't know. I honestly don't know. It really depends on what happens with, I think, 2 things. One, with Delta. So if Delta takes off and starts to cause a huge increase in infections, I think that it would be prudent for everyone to mask back up, because that's one of the ways we have. Again, it's a layered strategy. You have vaccines, you have masks, you've got your hand washing, you've got staying home if you're sick, you've got your social distancing. All of those things make a difference. And we put all those together, you end up with very few infections. Not zero, but very few. So it depends on what happens. If we get a lot of Delta out there, then there's going to be a recommendation to add some of those mitigation layers back in. If, on the other hand, we have lots of people who vaccinate, so if all of a sudden St. Croix County says, we got it, 80% of people get vaccinated, pretty good probability that's going to be much less likely to happen.
Right. And, everyone was yearning to get back to normal.
Absolutely.
Going
you
back
and I
to,
both, yeah.
To March the latter part of March was when it was announced we shut down the schools, we shut down our workplaces and everything for months. Nobody wants to go back to that level, but so you're saying that our best chance of keeping it as normal as possible and remaining to the point where masks are at least optional and not something that we need to protect ourselves and our family members would be vaccinations.
Absolutely. And I don't mean everyone has to be vaccinated. There are going to be those individuals who can't get vaccinated, or those folks who it just simply is not something they can do.
So can you explain that a little bit about there are folks who can't get vaccinated? What would be an example?
Yeah, so some people have had prior medical conditions that make a vaccine an unwise choice. Other people may have be undergoing certain therapies for other conditions such as cancers or other immunologic-oriented conditions where a vaccine just isn't going to be effective. And there are those few individuals who have an allergy to one of the components of the vaccine, although these vaccines actually have pretty few components compared to some of the ones we've used in the past. So I think that risk is lower for those folks.
Okay. When can we expect vaccines to be available for children under 12?
Again, good question. Don't know. I know that there has been some data submitted to the FDA that's under review right now.
And what would be the next age cutoff, do you expect?
Probably 6 and above is likely what we'll see next.
So school age.
School age, yeah. Although it could be, it could go younger if they've got good data and have enough data in. I think it's going to be sometime in the fall before we see that. It could be later. It could be a little earlier. Depends on when they get those pieces of data collected, because one of the things they're trying to do also is collect data from lots of different populations and subgroups. So they're trying to understand, does this vaccine behave differently in different populations of young children? And what's the correct dosage?
Right.
Because sometimes the child dosage is the one you use for adults. Sometimes it needs to be a less dosage. It really depends on the response, and that's also what they're trying to figure out.
Earlier we talked about FDA approval. Do you think that the FDA approval will get phased in similarly to how we phased in the emergency authorization, where it was, the different ages kept getting lower? Or do you think the FDA approval will just be everybody over 12 who's already been? Because it's been months, separating those people who got, the older folks got it first, so to speak.
Depends upon the data that's submitted. So if the data pool that was submitted to the FDA by, let's say, Pfizer or Moderna, because those are the two that have already submitted the information for full approval, if they submitted 12 and up, then the full approval could come for that age group if FDA feels that data is good enough. They could end up saying, we don't have quite enough data in the 12 to 18-year-old population, so we're just going to approve 18 and up. It could be that we need a little more information on one or the other pieces of the puzzle to approve for everyone. So,
and do you believe that would be a huge step? I've heard different pundits say that somewhere between 20 to 30 million people could get their vaccines within 30 days once that FDA approval comes out, because that's been kind of one of the big hindrances, if you will, to folks being hesitant to do it.
I don't know. I would hope that would help a lot of people feel more confident and be at least willing to proceed with the vaccine. I don't think I would say that those people would be comfortable because there's always a little concern when you do something. So I would hope there'd be a significant increase. I don't know for sure. Sometimes you have folks who say it's for this reason, but you take that reason away and they have another reason and they have another concern. And I just don't know how that would play out.
Right. It's not on our list of areas, but because it just happened like this morning, the NFL has come out and announced that in the league, because they don't want to go to a spot where there's going to be no games. It's all about the money.
Yeah. Yep.
They're saying if you want to play in the NFL, you got to get a vaccination, and if a team has a large enough unvaccinated, number of players, and they can't play because there's an outbreak, that there will be a forfeit of not just the wins and losses, which is huge, makes a big difference in making the playoffs or not, but also not even making your money for that game, forfeiting game money. So you're getting into kind of, instead of trying to incentivize, this is definitely more of a punitive measure, I guess, depending on how you look at it.
Yeah.
Do you think that this is a route that we want to go down? I mean, whether it's employers, schools, et cetera, when it comes to mandating vaccinations?
That's always a hard question. because you don't want to ever have to tell people that to do this activity, you have to have this situation. On the other hand, we as a reasonable society have said that for a lot of things. I can't go downtown and walk into a restaurant without shirt and shoes and expect to be served. It's one of those rules. If I get pulled over for a traffic stop and I'm not wearing a seatbelt, I should be cited for that. I can't blow through a stop sign in front of a police officer and not get a ticket. So there are some rules where we've said to do certain things, like driving a car, you have to buckle your seatbelt. To eat in a restaurant, you have to be wearing shirt and shoes. Do I want to see mandates? I don't, because I think people should have that opportunity to not feel like they were forced into things. On the other hand, when we look at it as a societal good, so to protect that population that's vulnerable, how do we manage that? Or in your case, you talked about the money. Well, they've made a decision related to the money. Whether I agree with that or you agree with that or not,
right.
is a whole other question. But they've obviously, the NFL has made a decision around that to say this is it. And for instance, the mask requirement on airplanes. The federal government has made a decision that to encourage people, make it more comfortable for them to travel, to support the ability for air transport in the country, to avoid large outbreaks and things like that, that this seems to be a reasonable thing to do because you've got a bunch of people in a small tube confined together for 2 hours, or 3 or 4 or 6 or 8 or whatever. And so I don't know. I think that's going to have to be a case-by-case, business-by-business decision.
Do you think we're changed when it comes, like, for instance, the optional wearing of masks? We've seen, because of the Asian flu and so forth and other outbreaks in other countries, wearing of masks is not that unusual prior to COVID in those countries.
Sure.
Do you think that we've changed here in this country, that that's going to be something that maybe something people do if they get a cold, a flu, whether it's actual diagnosed COVID or whatever, that they might mask up to either protect others or during the height of flu season, protect themselves?
Yeah. I hope so. I really do hope so. Not in a, nobody likes to wear a mask. On the other hand, if you're sick or you're exposed or you're worried about contracting those things, yeah, it makes a lot of sense. It works. I mean, there's a reason when I was doing surgery, I wore a mask. There's reasons if I was seeing patients and I had a mild cold, probably should have stayed home. But in those cases, I would put a mask on. And that was to protect the patients from getting illnesses from me, or if I'm doing surgery, from picking up a bacteria that I might breathe out that would get in that wound and cause a host of problems, very expensive ones. And so I would hope so. I mean, we saw what happened with influenza, with RSV, with pertussis, with all of those things last year. They dropped almost nothing.
Precipitously, right.
Precipitously. And so I think there's some real value to considering that. So again, if you're sick, stay home. If you can't stay home, put a mask on. If there's the infections in your community, put the mask on. Not a bad idea. So I think we'll see more people doing it.
So we may see more long-term change in mindsets, if not culture, when it comes to things like, I go to work no matter what, and even when I haven't had a sick day in 10 years, and now maybe more people will take seriously that if you don't feel good, don't go into work, because you're saving your employer a lot of hassle, you're saving your coworkers hassle and their families and so forth.
Yeah. I hope so, and one of the things I really hope that comes out of this is that businesses support and adopt policies that support people staying home. If you're sick, stay home. There's some early data that suggests that actually might be have a positive return on the investment for the business to have a little more liberal sick policy to allow people to stay home and work remotely if they're feeling up to working or whatever the deal is.
Well, that's a whole nother show, and we're now we're at the end of our 30 minutes. But yeah, definitely, I think that's another long term is. People are questioning, do we need all this real estate and office space if people can work from home? But
yeah, so that's another show.
If people are unsure if the vaccine is right for them, I think this is where important that we get this in, though, is if they don't think it's right for them, what do you want them to know and where should they go? Sure.
So I think a couple things. First off, 161 million people in this country have been fully vaccinated. 43,000 people in St. Croix County have been fully vaccinated. Yes, it doesn't have the full FDA approval yet. I think that will come in time, to be honest with you. It does have an emergency use authorization. Nothing has shown up as being really alarming. Yes, there have been some concerns, but nothing really alarming. So I think we have some pretty good information. 43,000 is a pretty darn big number, and that's just here, that it's safe and it's effective. We've seen the drop-off in rates. That's been phenomenal. I'm hoping it continues. I'm hoping we don't get the Delta surge.
Yes,
the rates of COVID. I'm hoping that it doesn't continue to rise as Delta gets out here. So I think that that's the first thing. The second thing is people should talk to folks they trust. Talk to people who've had the vaccination about their experience. Talk to your physicians. 96% of the physicians in the nation have been vaccinated. That, to me, says something. And so there's plenty of folks you can get that information from. Ask the good questions. Listen to people who really have a lot of good information for you. I think where can you go to get vaccinated? Basically, pretty much almost anywhere. The county runs a clinic every Wednesday from 1 to 3. The pharmacies, many of the pharmacies in the area have vaccine readily available. You can walk in the door. You don't have to have an ID. You don't have to be from Wisconsin. If you're under 18, you do have to have a parent with you to say, yep, it's okay.
We've come pretty far in 5 months, haven't we?
Yeah, we have. We've gone from that scramble to try and get them because they simply weren't widely available. And I think the county and Wisconsin did a great job of vaccinating those folks who were most vulnerable and most critical first and working it down. It made lots of folks impatient in the middle. I get that. But now we have an abundance of vaccine. In fact, they're talking about having to throw away millions of doses in August because it's going to expire. And it's there, it's available, it's easy to get. Your clinics have it too. In our county, Pfizer, Moderna, Johnson & Johnson, any of them are available.
Okay. And is there one or two websites that you would point people to go in more further depth of the subjects you've touched upon here?
I do believe that the CDC provides credible information. I don't always agree with everything they say, but I haven't found anything that causes me to say that's really, really wrong or that's really, really dangerous. So I think they provide good, solid information. They acknowledge where there's gaps in information. They acknowledge where there's discussion or controversy around information. So I think that's a pretty good resource. I think that the county has done a great job of putting up good information, so that's a reasonable place to start that process, and there's also links on there. And then if you don't want to go into the governmental sites, you can certainly look at Mayo Clinic, you can look at the Cleveland Clinic, you can look at Health Partners locally. There's lots of places where you can get good, reliable information and start that process of digging deeper and understanding more about the questions you might have related to a vaccine.
Dr. Paul McGinnis, thank you for joining us, and we'll hopefully not promise to have you on in 6 months, but you're willing to come back on if we need you, right?
Absolutely.
All right. Well, thank you for your information. Very enlightening. And I want to thank our viewers for watching another segment. We want to have a very informed audience, and we hope that folks listen to Dr. McGinnis here and do your research and contact your professionals and people who you trust, and I hope you make the decision that's right for you. Anyway, thank you for watching, and we hope you keep watching Western Wisconsin Journal. I'm Jamie Johnson. Thanks.